Welcome to the Cambridge Neuroscience Interdisciplinary Seminar Series. This series features current work from across the schools, departments and institutes that form Cambridge Neuroscience here at the university and will reflect the pioneering work and diverse interests of our members. Cambridge Neuroscience is currently going through quite a detailed consultation process to develop 6 new themes to reflect the research we do here. Each of the talks in this series will come from one of these themes. For more information on the themes and the talks covered in this series, please follow the links below and follow us on Twitter at CamNeuro.
So without further ado, it gives me great pleasure to introduce Dr. Nicholas Evans. Nick is a good friend of mine, but he is also a clinical lecturer in stroke medicine here at the University of Cambridge. He is also a stroke consultant physician at Addenbrooke's, and his primary focus is on imaging arteriosclerosis. So we all know about, of course, the hardening of arteries due to cholesterol. Nick is also a fellow of Wilson College. So as you'll probably kind of gather, Nick is a great example of what this series is all about. His work focuses on research from all different departments working together. So medicine, clinical neurosciences, geriatric medicine, radiology. So it's really exciting that we have you here today, Nick, to open the series. So over to you, Nick.
So thanks, Dervila. It's a real pleasure to be here in the first of this year's seminar series. And I think I'd just like to echo what Dervila's just said, is that I think that actually this interdisciplinary nature of neurosciences is a real plus. And I think the broad church of neuroscience and being able to bring everybody together to form sort of collaborations, research questions, hypotheses together, I think is a real strength of the collaboration. And actually stroke medicine overall is a very collaborative effort. So we at Addenbrooke's work hand in glove between researchers and physicians, nursing team, allied health professionals to be able to improve the treatment for individuals with stroke and also their recovery. And today I'm going to be talking about some of our neurovascular imaging work. And I'm conscious, and Dervila's sort of put it very well, is that this is a big collaborative effort between a number of different departments. So I'm going to focus beyond the brain and also to include imaging of the blood vessels supplying the brain, how they relate to what is going on within the brain, but also relate how they influence an individual holistically and may impact upon their stroke presentation and recovery. So in other words, what I'm going to be doing today is talking us through from the vulnerable atherosclerotic plaque to the vulnerable brain, and then finally as well then to the vulnerable individual. But I think it's worth keeping all of this in context. So over the course of the hour for which we'll be meeting, 12 people in the UK will have a stroke. It's one of the leading causes of adult disability in the UK and affects not only the individual, but their families, carers, healthcare, and the UK economy as a whole, with an estimated cost of £26 billion per annum. So the scale of the challenge we face is vast. Now, I'm conscious that part of the theme of these seminars is to go beyond the neuron. And actually, this is a topic of discussion that's been taking place in stroke now for quite some time. And there's almost sort of two schools of thought that have consistently discussed about the nature of stroke as a disease. You have those individuals who say, well, of course, it's a neurological disorder. It affects the brain as perhaps the primary neurological organ. And then on the other side, you have those individuals and saying, well, of course, it's a vascular disorder. This is essentially plumbing. The minute that you get then an obstruction for the flow of blood through your arteries, and remember, 80% of strokes are ischemic strokes, where you get a blockage in the artery, and without the blood and without the oxygen it carries, subsequently then that area of the brain dies. So of course, in reality, this is a very false dichotomy to draw apart these distinctions. But what I would say is it just really reinforces that perhaps stroke is the epitome of a disorder, of a medical condition, where actually we are focusing just beyond a single organ to actually consider actually the systemic effects that are having on the brain, but also as well on the individual stroke survivor. And as Derval has said, my particular area of research interest is in carotid atherosclerosis. So the hardening of the artery, the main blood supply going up to the brain. And that's the artery you feel when you feel the pulse in your neck. Now, I mean, for sort of historically, there was a consideration that this furring up within the arteries impeded the flow, and that's primarily what then caused the stroke. But we realized that actually it's far more complex than that. And actually this area of atherosclerosis, the hardening of the arteries in response to the cardiovascular risk factors with which we're all familiar, of smoking, diabetes, high cholesterol and high blood pressure, we realized that actually this area represents a nidus of inflammation. And this inflammation is a process that can cause then the plaque to become unstable, to become damaged, and consequently then form blood clots that subsequently break off, travel up into the brain and cause a stroke. And we can think about that in terms of the natural history of the schema. So from a normal artery, in response to the damage with those cardiovascular risk factors that we've mentioned, you get an infiltration then of immune cells into the lining of the blood vessel wall, and the atheroma then starts to develop. At the other end of the scale, or the end of the pathway, you end up then with a plaque then that is beginning to burn itself out. It is beginning to calcify, and there is still some discussion about what the sort of calcification there really sort of what the implications are of that. And the general feeling is that actually that's the plaque beginning to then stabilize, because effectively what you can't do is rupture a big piece of chalk within the artery. But the critical point, the bit that is obviously of most concern to me as a stroke physician, is the point at which then through a combination of enzymatic destabilization or mechanical disruption to the atheroma, that ruptures then, causes then a blood clot to form, and it's that clot that then travels up into the brain to cause a stroke. Looking at that area a little bit more, I've already mentioned about the interaction between inflammation and also mechanical destabilization. And the way it happens is through inflammation driving the deposition of small deposits of calcium, microcalcification, less than 50 microns in diameter. Those are deposited then in the cap that overlies the atherosclerotic plaque. And in so doing then, that damage to the plaque then firstly drives further inflammation into a potentially a vicious cycle. And then there's one of two exit routes. Hopefully, it's the case that this microcalcification coalesces and then causes then the plaque to become more stable. However, what may happen is that actually it causes these microfractures. And it's that mechanical destabilization then that can cause then the plaque to rupture and clots to form. So this is a histological specimen that really just illustrates this. So here, this is a cut through the carotid artery. You've got the blood, the lumen of the blood vessel running here, and you've got the atherosclerotic plaque running down. You can see these small deposits of calcium, microcalcification in this region here. Now, the difficulty that we face within clinical practice is that most of our conventional imaging, so with Doppler ultrasound here, or with CT or MRI angiography, is that we are not able to visualize these processes. We can see surrogate markers of them, and we can see the degree of stenosis within the plaque, but what we cannot see is to directly visualize inflammation or microcalcification. The microcalcification falls below the detection threshold for an MRI, as I said, at about 50 microns. So in clinical practice, we are largely still going by the degree of stenosis. But again, this is a very sort of dated approach, and one that is rather crude. And even back in the late 90s, through Peter Rothwell and Charles Warlow's work, we realized that actually the degree of stenosis, the degree of narrowing in the blood vessel only tells part of the picture. And we can see this through looking at the natural history of people with carotid atherosclerosis. So they came up with a predictive risk score, and it factors the different features that you'll see there, of which the degree of narrowing counted for a maximum of 2. And you'll see here, those were considered low risk down to a score below 4, that was the overall pattern then of stroke-free survival. And you'll see then that sort of the occurrence of stroke then over a 5-year period. If you then compare it then to individuals who had a higher risk, and remember, this must factor in then other factors other than the degree of stenosis, which count for a maximum of 2, you can see that actually then the rate of incidence of having a stroke related to the carotid then is much higher over that period. So it's more than just the degree of narrowing, and what it must indicate then is that some of these other physiological processes we've mentioned, or some of the other sort of physiological characteristics of the plaque must be playing a role here. So with that sort of challenge in mind then, how can we go about sort of addressing this issue? So in the first part of this talk, I'm going to be talking a little bit about identifying the vulnerable atherosclerotic plaque. And our research program up at Addenbrooke's and with the university is using a specialist technique called positron emission tomography. Now, this is a technique that's been used quite commonly in the past within and used routinely in clinical care within cancer care, and being able to then detect physiological processes non-invasively in vivo. So this scan I realize we've got a range of individuals here of sort of preclinical scientists, clinicians, and also as well members of the public. This scanner there is about the size of a CT scan and is a combined scanner that involves an element of a CT scan, but also as well this PET scanner. And so our imaging, it takes about 15 minutes to do. And the way that it works is that we inject an individual with a radio tracer. So it's in effect a targeted radio tracer that targets a physiological process of interest. And we'll talk a little bit more about this as we go. But essentially it's radio labeled. When it then accumulates in a tissue of interest, representing the physiology of interest in that tissue, what then happens is the positron is then released then through the proton decay. That positron then encounters electrons, gives an annihilation reaction in a gamma burst, which we can then subsequently then detect using PET. If you combine that then with the anatomical features of a CT scan, we can then localize in 3 dimensions where that sort of physiology is within the human body, as I said, non-invasively. And we've been using this technique really since coming up to about 20 years ago, when James Rudd did the first study looking at the use of FDG. And so fluorodeoxyglucose is a radio tracer analog of glucose. And as you will expect, is that it gets taken up in proportion to the metabolic demand of a tissue. So a more metabolically active tissue, you will see then increased uptake within that area. It competes with glucose that's in the circulation, but it behaves slightly differently. So it doesn't enter the glycolysis pathway, but what it does is it then accumulates, as I said, in those regions of interest. And we'll show how it then relates to that in a blood vessel very shortly. So FDG has been the mainstay of vascular imaging now for, as I said, for quite some time. And this has been validated against histological specimens. So one of the procedures that we do within stroke medicine, if we find an individual with a narrowed artery, is to remove some of that obstruction using surgery, a carotid endarterectomy. And by matching then the burden of macrophages, then the inflammatory cells within the plaque on the excised histology following the operation, we could see that that was associated then with the FDG signal. So in other words, it validated it against the histology. So I've said FDG has been used for a little while, and we'll talk a little bit about it shortly. But actually what is been much more recent is the use of being able to detect microcalcification, this mechanical destabilization because of the small deposits of calcium that are below the detection threshold for the MRI. And we do this by using a sodium fluoride tracer, or NAF. And this is incorporated at sites of active microcalcification within the tissue as a consequence of osteoblast-like cells that are lying down calcium there. So it's a very similar process actually to almost what we see within bone. And so our first question when we started this work back in 2013, 2014 time was to see whether or not we could identify and differentiate between culprit and non-culprit atherosclerotic plaques using sodium fluoride PET. And in order to achieve this, we devised the Icarus study, perhaps an example of where coming up with the mnemonic almost took as long as it was writing the protocol. And what we tried to do was to come up as much as possible a almost purely carotid model of stroke in a real life sort of human patient population. So we recruited individuals who had a significant narrowing of their artery, 50% or more, who were able to really sort of reflect a purely carotid model of stroke. So as you'll see there, I'm not going to go through all of the inclusion and exclusion criteria, but other than to really highlight that actually this was quite a sort of challenging and quite a sort of a specialist study to be able to get it as pure a carotid model as possible within the human population. And the participants that we recruited were really, as one would expect from the nature of the vascular disease. So they were typically in sort of older individuals in their 8th decade of life on average, predominantly men. They were, majority were either current or former smokers with the cardiovascular risk profile of high blood pressure that one would expect. And these are the images we get. Now, for those who are less familiar with looking at imaging, I'm just going to put a caveat right at the beginning, is that we are looking at these images as if we are looking at an individual from their feet, almost looking through the bore of the scanner. So for that reason, this individual, that is their right-hand side, this is their left-hand side, and I'll point the structures as we go. But when I refer to right and left, that's the right-hand side, that's the left-hand side. So in this individual, this is a CT scan. This is an angiogram showing their carotid arteries there. This is the PET scan that I mentioned earlier on, almost sort of a mood stone-like appearance there of tracer uptake. It's almost, it feels one almost has a PhD in colouring in, and one can overlay then these two different aspects, the PET and the CT scan, to be able to identify where these physiological processes of interest, where they relate to in the anatomy. So in this individual's case, they had an asymptomatic or non-culprit right carotid artery, but in their case, they had a symptomatic, a culprit left carotid artery. And hopefully, as you can see, that actually, and visualize very well, is that there's this red hot area that corresponds to their carotid artery. So we can already identify and differentiate then between the culprit versus non-culprit side. But we've seen here mainly about detection, but as well as being able to detect it and visualize it, we're able to quantify these processes. And we can do that in a number of different ways. So we can either start off by looking at the single hottest point along the length of an artery, the so-called single hottest slice. SUV max, so that's a measure of tracer uptake. It is basically the tracer uptake measured in that area, adjusted by an individual's weight and the injected dose. So it's just a way of being able to quantify the tracer uptake in that region. We can either measure it at the single hottest point, perhaps a more representative region for the atherosclerotic plaque, as the three contiguous 3 millimeter slices. So in other words, about the most diseased 1 centimeter of the carotid artery. But we can also as well consider the whole length of the carotid artery. And taking the average, really representing the sort of the uptake along the entire length of the artery. So when we looked at sodium fluoride uptake, we could see that the more focal measures, the single hottest slice and the most diseased segment, is that we could see that the uptake was significantly increased in the symptomatic side compared to the asymptomatic side. However, when we considered the entire length of the artery, then that did not reach statistical significance. And that, to us, indicates that actually the microcalcification process is a very focal process. And as I said, it's mainly focused around that most 1 centimeter, the most diseased 1 centimeter within the carotid artery. And we can see this by reconstructing the images that we've got into a 3-dimensional model. So here's an individual with a symptomatic right carotid artery with the uptake in that sort of greeny blue area that you'll see there. And as you see, getting close to it, this is very focused around the right carotid bifurcation, where the common carotid artery divides up into the internal carotid artery and the external, with the internal then going up into the brain. And going back to the degree of stenosis again, just to highlight that there was no significant relationship between the degree of narrowing and the sodium fluoride signal uptake. So again, it's coming back to the fact that the physiology is much more important than just simply the degree of narrowing. So, okay, so far so good. We've shown that microcalcification, the mechanical destabilization of the plaque, we can differentiate using PET. But what about then what about inflammation, the process that I've already discussed in terms of contributing to the development of the atherosclerotic plaque and its more sort of chemical instability? Because the matrix metalloproteinases as part of the inflammatory process can then actually cause a collagenase effect that causes then the breakdown of the atheromatous plaque. And we measured this, as I mentioned earlier on, with fluorodeoxyglucose, the analog of glucose. And we can see here, this is just as an illustration, again, here's somebody's symptomatic right carotid, which again highlights then as sort of heating up then to indicate the inflammation in that region. So going back to how we were seeing already with the sodium fluoride, in this occasion, we see that actually the uptake is much more diffuse. We see that, yes, in the symptomatic arteries, the more focal measures, the single hottest slice and the plaque, the most diseased 1 centimeter, is significantly higher. But we also see that if you look at the average along the entire length of the artery, the symptomatic side then is much higher, is significantly higher than the contralateral non-culprit artery. So this to us indicates that there are two distributions of these processes. Inflammation being much more diffuse along the length of the artery, whereas actually the microcalcification is much more focal. And again, that signal of the inflammation was not related to the degree of stenosis, but what one can then chart out then is actually about how these the readings distribute along the length of the artery. So I'll talk you through this slide, is that on the blue here is the sodium fluoride, the microcalcification. On the right-hand side of your screen is the FDG, the inflammation. Across the top is the culprit symptomatic arteries. Along the bottom there is the asymptomatic non-culprit arteries. And what you can see here, these are different 3 millimeter slices along the length of the carotid artery, and 0 corresponding to that carotid bifurcation, the point where it divides up. And you can see here that the peak in microcalcification activity corresponds to around the point of the carotid bifurcation. In the symptomatic side, it comes to this very sort of marked peak. In the non-culprit side, it's a much more attenuated response. But again, with the eye of faith, you can see that sort of starting to peak around there. In contrast, the FDG, as we've already mentioned there, is much more diffuse. There's no single sort of real focal point here. It's much more diffuse along the length of the artery, higher in the culprit artery when compared to the non-culprit. But we can chart that again along with the imaging. We can see with the FDG, the uptake along the entire length of the artery reflecting that, in contrast to that peak of sodium fluoride that we see around the bifurcation showing there. So that, in terms of the first part of our story, is that we're able to identify non-invasively the vulnerable plaque using 2 different tracers within in positron emission tomography, and we are able to identify these 2 different processes involved in plaque vulnerability, that vulnerability to rupture and subsequent stroke events. But what it also furthermore has shown is that these distributions are distinct. Microcalcification is focal, but actually inflammation, that inflammation within atherosclerosis is actually much more diffuse. So it goes beyond just the point of rupture, but actually along the entire length of the vascular system and along the length of the artery. Now, let's say I was just interested in the blood vessels themselves, then that would be the end of our story. We would have this understanding. But actually, as a stroke physician, I want to know what effect this has on the brain. And for those of you sort of chomping at the bits to know a bit more about the brain and as neuroscientists, let's move on a little bit then to finding out about how this pro-inflammatory environment, this sort of systemic inflammation, how it may affect either the brain in the kind of chronic state or potentially as well the evolution of the stroke in the early stages. So within conventional imaging, we use a combination of CT and MRI in our clinical imaging. This here again is a CT scan of an individual's head, and in this case, and remember the right-hand side, left-hand side, as we've already mentioned, this is showing actually the very early stages of evolving stroke here. You can see the well-defined structures on the left here. This is a little bit more nebulous. But the way I think about CT and MRI is it's almost a bit like looking at an analog signal with a digital signal. CT scans can tell us a lot about the structure, but again, what it doesn't do is potentially expose or show us in greater detail about some of the processes going on from a vascular perspective, which is where MRI then comes into its own. So these are flare sequences as part of the MRI sequences, and really what we can do using this is to assess the overall burden of chronic small vessel disease change. And I'll talk a little bit about what that represents shortly. But essentially is that the brain and the arteries as they go through the brain are getting increasingly smaller to the point where they reach the structures quite deep within the brain. Now, these particularly small arteries then are, through a process of different mechanisms, exposure to hypertension, will potentially thicken and may potentially start to obstruct, as well as potentially become more leaky. And this then causes chronic changes then deep within the brain. It causes gliosis and and potentially as well demyelination. Now, this can vary then in an individual in terms of the extent. One individual will differ very much from another then in terms of the extent of this small vessel disease. So we can measure this using something called the Physica scale, which is a sort of an ordinal scale then that looks at a sort of a semi-quantitative measure of the degree of small vessel disease, but we can also as well measure the volumes directly. But to have a look at it, this is an individual stroke. Here we can, for the purposes of looking at the chronic brain changes there, we can largely ignore that. But hopefully what you can appreciate in terms of looking at these two different scans is the area around the ventricles deep within the brain. Here there is sort of little sort of ring around it, and overall that looks a fairly healthy brain aside from the stroke there. But what you can see in an individual with more extensive small vessel disease is you see this then sort of increase, what we call leukoariosis, surrounding then these the ventricles here deep within the brain, and that represents then sort of chronic change. And why is that important? Well, actually it's because the chronic small vessel disease plays a major role then within vascular dementia, the second leading cause of dementia after Alzheimer's. And as we've just seen on those scans, it exists in a spectrum between potentially small ischemic strokes, where if one of those small blood vessels is occluded, or a more diffuse then exposure then over time, if there's a sort of a much more widespread involvement of these smaller arteries deep within the brain. And as I've said, there are a number of different mechanisms sort of suggested to play a role within this area, including impaired cerebral autoregulation, the narrowing, as we've said, and actually just a sort of failure of the blood vessel lining and increased then permeability into the surrounding tissues. But as well as the cognitive impairment and dementia, it may also as well play a role in mood, and so it's been associated with depression, but also as well physical disability, such as it's associated with increased risk of falls, and also as well urinary incontinence. So it can have a really marked effect on an individual's quality of life. And this is some work from Jess Walsh and also Robin Brown in our group, where they've looked at around these areas of small vessel disease, around the areas of leukoariosis. We've seen sort of two main features. Firstly, that there's increased blood-brain barrier permeability. Remember the blood-brain barrier being obviously the main point in terms of buffering then the systemic changes from the intracerebral environment. And also as well by using, again, PET imaging, using PK11195 that looks for microglial activation, you can see that there's neuroinflammation in these areas around the edges of the small vessel disease. Again, these are associations rather than causative, but you can clearly see that that's around the sort of edges there of the small vessel disease. And are these the processes then that are potentially driving then the development of small vessel disease? And this is some work that's a little bit older now, from the Manchester group, that looked at how, again, this is our PET imaging of the brain using PK11195 targeting microglia, that have shown that actually in individuals, the ones at the top row here, individuals with a more adverse cardiovascular risk factor profile, so individuals with these cardiovascular risk profiles we've mentioned earlier on, this is in the absence of stroke, but just with these risk factors, there appears to be more neuroinflammation diffusely than those individuals then who are matched but without the cardiovascular risk factors. And so their conclusion is that this, in a way, primes the brain for injury. These systemic then features of cardiovascular risk factors potentially then prime the brain for injury with neuroinflammation. And this is just really a schema to potentially sort of recognize some of these factors about the link then potentially between the atherosclerosis, which remember is an inflammatory diffuse condition, and the link then with potentially the downstream effects on the brain. So we've mentioned about the cardiovascular risk factors promoting atherosclerosis, promoting inflammation, which then may in turn then cause disruption to the blood-brain barrier permeability, because of associations with matrix metalloproteinases, but also as well by priming the brain with pre-existing neuroinflammation. So what we wanted to look at in individuals who are coming in with stroke related to carotid was actually then, could we look at the inflammatory activity within the carotid arteries and see whether or not that influences then either the presence of small vessel disease at the time of baseline, and also as well an adverse evolution of their infarct over time. And this is what we saw, is that we found in individuals where there was, these are the scans you saw earlier on, those with sort of relatively little small vessel disease, yes, a little bit of inflammation, but actually it's overall fairly quiescent. In contrast, those who have the much more extensive small vessel disease, then actually they showed high degrees of inflammation within their carotid arteries, within the atherosclerosis. And when you adjust that then to a range of then different factors, that came out as being then independently associated. And we looked at it both from the point of view of the culprit artery, the one where the plaque had ruptured, but also as well the contralateral non-culprit artery. And we looked at it then from the measure of the most disease segment of uptake, but also as well the diffuse measures of uptake. And really the point of this slide here is to show that actually the strongest associations came from where we considered the inflammation diffusely along the non-culprit artery. And this probably is much more of a barometer about what represents then the sort of an overall barometer of the overall activity of atheroinflammation, the inflammation within atherosclerosis. It's much more of a barometer of the systemic effect than the disproportionate rise within a ruptured carotid plaque. But we also as well wanted to look at the evolution of the infarct in the early stages after a stroke. And by that, we were talking about the first 90 days. And again, we can measure the size of the infarct using the flare volumes that we saw that match up then with a sequence called diffusion weighted imaging on the MRI scan in the early stages of a stroke. And we can measure these volumes sort of off the MRI scans. So we did the MRI imaging at baseline within the first week of stroke, and then repeated it then at day 90. And we found that there was an association again between the degree of atheroinflammation within the carotids and an adverse evolution of the flare lesion, the stroke lesion, over the course of the time period. So we saw that the hotter the arteries, the more higher the uptake of FDG, and that was associated then with an increase in the size of the infarct over time, whereas actually those that were more cold tended to then actually decrease a little bit in size overall. And again, actually the tightest relationship, the strongest relationship, was when we considered the non-culprit contralateral artery, where we looked at the diffuse measure of inflammation. So again, that barometer of overall inflammation within the vascular system, rather than the disproportionately raised area within the actual atherosclerotic the culprit atherosclerotic plaque itself. So again, the overall systemic exposure of atheroinflammation. So in terms of the summary from this aspect, we're starting to see then how the vulnerable atherosclerotic plaque, the vulnerable atheroma with diffuse inflammation then was associated then with both acute and chronic cerebrovascular disease severity in terms of both small vessel disease and also the adverse evolution of the infarct over the time period. And most of that is coming then from, and the tightest relationship is from the systemic markers, the barometer then from the non-culprit artery that's really sort of measuring that background level of atheroinflammation. So that's talking about, we've covered the arteries, we've covered then the downstream effects then of atheroinflammation and on the brain. But what about these changes on the individual? So again, when we go to the emergency department to see somebody coming in with a stroke, we see the individual who's coming in as they are and their recovery as well. And this is of particular interest to me as a clinician in terms of then linking these other sort of radiological features about how actually somebody, their clinical course behaves. And I'm going to take a step back first, because actually an area that's of particular interest to me is clinical frailty. Now, clinical frailty is a loss of physiological reserve to be able to withstand an insult. Now, we all know in our day-to-day lives individuals who are older, but actually show a range of different sort of levels of function. So I realized this is a slide that I put together a little while ago now, and I realized that sort of both Bruce Forsyth and the elder George Bush, President Bush, have died, but I think they were the same age around this time, and I think it really sums up the differences we see. Here's somebody who is very active, still dancing, and actually physiologically is much younger than their chronological age. In contrast here, the elder George Bush, at that stage, despite being around the same age, clearly there is much frailer, and in terms of their ability to do things then is much more reduced. It also as well, I think, shows about how you put somebody in a hospital gown, immediately then they look that little bit frailer. But it goes to show it's not just about the number of times you've been around the sun. And actually there is a functional decline, a loss of physiological reserve that means that you're unable to withstand stressor events. And it means that you're probably less able to bounce back as quickly from a stressor event like a pneumonia or an infection, or indeed a stroke. And it's distinct from age. So although we know that the prevalence of frailty increases with age, as we have just seen, and from our evidence in our own lives, we know there are plenty of individuals who are sort of, although they are at the older ages, are still actually behaving like almost they're 10 or 20 years younger than their chronological age. And this is a very good illustration by Andy Clegg. And it just goes to show this is a passage of frailty, but for somebody who's more robust, as shown by the green line, so less frail, is that they come along, they have an illness such as a urinary tract infection. It causes a slight decrease in their level of functioning, but they recover fairly quickly, probably back to where they were before. In contrast, the individual in red, who is frailer, already starting from a lower level of function, has the same insult, drops off much higher, much more pronounced drop off, takes longer to recover, and very often they don't get back to the same level as they were before. And we see that actually across different sort of categories of frailty, that affects then the sort of mortality then, and we can see that actually that you can almost classify them into 3 distinct groups then over the follow-up period. At Addenbrooke's, we use the clinical frailty scale. So it's a very easy to use score that considers the individual, how they have been prior to coming in for their stroke in the 2 week prior to this, and basically almost kind of scores it a little bit against individuals as sort of similar to their age. From the very fit to the point where vulnerability starts creeping in at about level 4 to the point where actually they're already sort of pre-existingly quite frail. And we looked at the individuals who came in with ischemic stroke to our centre. And we found that if you want to just dichotomise it simply along the lines of whether they were frail, those clinical frailty scale of 5 to 8, or non-frail, we could see that those who were frail typically ended up then were older. And because and were more often women who were frail, but that is very often a product of actually men dying off that little bit earlier. So women, because of their longer life expectancy, that increasing rise of frailty as they get older goes with it. But what we did see is that typically the length of stay was up to a week longer, and also as well with a rough 3 times then higher mortality rate at 28 days. And after then, if one considers it from a multivariable perspective, is that we saw that this remained independent, that frailty score, as we saw in terms of with each increasing frailty score, there was an odds ratio of mortality at 28 days of 1.03. But what we also saw as well, that in response to our hyperacute reperfusion therapy, so if somebody comes in with an acute ischemic stroke within 4.5 hours with a blocked blood vessel, we can try and reopen it then with alteplase, a thrombolytic drug that breaks down the clot. And we found that in the individuals who were non-frail, we could see the NIHSS as a measure of stroke severity. We could see that there was a significant reduction in the severity of their stroke from a sort of, on average, a moderate severity stroke down to a milder level of disability in their stroke. In contrast, those frail individuals, despite coming in with roughly about the same level of stroke severity in the first instance, we saw actually a marked attenuated response to then the acute therapies to their stroke. So the non-frail individuals tended to benefit, the frailer individuals then, that benefit was attenuated. And we could see that roughly then, for each increasing 1 point on your clinical frailty scale, you had 1 less point improvement in your stroke severity measured by the NIHSS scale. And with every 1 point increase on your NIHSS, your relative chance of making an independent recovery reduced by 17%. So actually 1 point can make a big difference to an individual. So part of the question is why this phenomenon exists. Why is it the case that individuals then who are frailer have an attenuated response? And you may remember that I'm coming back to then this concept of the vulnerable individual. Well, at Addenbrooke's, we have a specialist scan that can measure not only the structure of the brain, but also as well, we, in all acute stroke cases, use CT perfusion imaging. And this gives us a measure then of actually what is going on within the tissue itself. I'm not going to go into this too much detail other than to highlight the real sort of key aspects. Cerebral blood flow measures then the effect and the overall involvement of the area of the stroke in terms of the reduction in blood flow. So in an individual here, we can see that the blockage in the blood flow is affecting most of the right-hand side of their brain in the cerebral blood flow. The cerebral blood volume corresponds to it's the core of their ischemic stroke, of their infarct. Now, as you might imagine, this mismatch between that area there and this larger area here represents area that actually we've got reduced blood flow going through, but has not gone on yet to go on to form an established stroke. And that represents potentially salvageable brain. That represents something called penumbra. So that here, in this individual, there is a very favorable perfusion profile for lots of brain to salvage. Sorry, Derville, my computer is frozen. There we go. In contrast, here is an individual who you can see the cerebral blood flow is involving most of that hemisphere and a large area reduction in the cerebral blood volume. This is a large area that is largely matched and representing that actually there is relatively little brain here to salvage. Both of them have pretty good plain CT scans, but we can already see that the physiology is behaving quite differently in these two individuals. And what recent work has shown is that actually frailty has been associated then with a much more a significant reduction in the size of the penumbra, the reduction in the size of the salvageable tissue. So we see that in those individuals who have a higher frailty score, is that actually these individuals then have a higher proportion of established core infarct out of the whole lesion volume. But also, we also found as well that frailty was associated then with an inflammatory marker something called C-reactive protein. Already there is a large sort of feeling that that actually frailty may represent then an inflammatory process. We see in terms of from this study here is that this is the cohort individuals who are frail and also as well already have sort of higher markers there of inflammation, and those where there's even more inflammation then do more poorly. So we looked at then in terms of whether, bearing in mind, we've already said that there's a link between frailty and inflammation. Is there a relationship between the inflammation within the inflammation within atherosclerosis and overall sort of the clinical picture of clinical frailty? And we found that there is. So on a univariable analysis, we found that there was an association if you looked at the amount of inflammation either in the culprit artery, or again, the stronger relationship was with the non-culprit artery, again, acting as a barometer then for the overall level of inflammation within the system. And that remained then independent then when we adjusted then for a range of other cardiovascular risk factors, including in particular age and smoking. So actually there is a strong then association between what's going on within your blood vessels and actually what's in terms of is being manifested more broadly in terms of frailty. And that frailty then, as we have seen, relates then back to potentially what happens with your penumbra in terms of how much brain is salvageable when you come in with the stroke, and also as well the outcomes following stroke. And that's essentially what I've just said there. So those are the summary points about how we're linking then vulnerable plaque to vulnerable brain to vulnerable individual. But just before I close, I just want to highlight, well, this is all well and good, but actually really what are we going to do with this next? So we have a study that's begun that's called the Daedalus study that is looking at the level of inflammation within the carotid arteries and within the brain in one sitting. So rather than potentially do a scan of the carotids and then subsequently do an MRI down the line, we can actually do this using the MRI PET machine up at Addenbrooke's. We can use this then to look at concomitant inflammation between the carotid and also within the brain. And the MRI gives us a much better sort of anatomical reference as well. So it gives us more information about the plaque. Here's the CT scans that we've already mentioned, whereas actually when you then get it with an MRI, you get much better anatomical differentiation. Now, the other study that we're doing is actually about what about intervening in things. Now, we have started a study using sodium valproate. Now, this is based on an observation that individuals who are taking sodium valproate, which is a commonly used anti-epileptic medication, there is, after their stroke, if they are taking that medication, if they're on it beforehand and continue to take it because of their epilepsy, they appear to have a reduced then incidence of stroke compared to those who either aren't on sodium valproate, or even if you compare it against other anti-epileptic medications. So why this has been noticed at a population level, what must it be that's going on here? And if one then looks at it then at a molecular level, we can see that actually that sodium valproate inhibits the gene HDAC9, and that is through a GWAS analysis been found to be associated as a risk factor for carotid related stroke. So HDAC9 seems to have a role to play in the promotion of carotid atherosclerosis, and in mice models where that gene was knocked out, then actually there was reduced rates of atherosclerosis. And from what we have seen so far in animal models, sodium valproate appears to inhibit that. So what we are doing is we are recruiting individuals who have had a recent stroke related to carotid disease, and we are trying them on sodium valproate versus then conventional, so alongside their conventional medication, to see whether that reduces then the amount of inflammation as we see on their FDG PET. But thinking back, what about microcalcification? Well, again, through some animal work, we have seen that minocycline, a commonly used antibiotic, sort of particularly around acne, has the potential there has been seen to inhibit the active microcalcification process. So again, we're using a similar approach. We're going to be recruiting individuals who have had a stroke related to carotid disease and starting them on a 12-week course of minocycline to see whether that reduces then that microcalcification signal associated with the vulnerable plaque. So that's really sort of in a whirlwind, a whistle-stop tour is really looking about how, by thinking about the vulnerable plaque, we can think about how using PET, we can differentiate culprit then from non-culprit atheroma in vivo. But actually the processes going on within the blood vessels and within atherosclerosis have a downstream effect on promoting both the chronic small vessel disease associated with vascular dementia, but also plays a role in potentiating the evolution of the acute infarct. But also as well, what goes on within the blood vessel is also associated then with frailty, potentially associated with less salvageable brain and poorer outcomes then after stroke. So we have seen how then the link between a vulnerable plaque can affect a vulnerable brain and subsequently then a vulnerable individual. And through this then, we hope that we're better able to understand the diseases themselves, potentially, as we have seen, open up for novel therapeutic targets, to use then as a way of potentially being able to monitor responses to these treatments, either in research or clinical settings, improve prognostication, or for the 12 people that have had a stroke whilst I've been talking, better still to have stopped them having a stroke in the first place. Lots of people to thank as part of this, obviously. Everybody that you've seen on there has put a lot of work into this. Support from Wolfson, also as well my funders, the Dunhill Medical Trust, the Academy of Medical Sciences, the NIH, National Institute of Health Research, the Cambridge BRC, all the participants. This has been quite an involved series of research. To be able to take part in all of this in the early stages after a stroke, I think really shows their commitment. So certainly their thanks to them, and also to all of you for listening. And with that, I'll bring things to a close and welcome any questions that you may have.
Thank you, Nick, for that great talk. Join us next week when we welcome Professor Thora Karadottier. Thora is the director of the MS Society Cambridge Centre for Myelin Repair. Following an undergraduate in Iceland and a PhD at UCL, and then a number of career development fellowships, we are delighted that Thora joined us here in Cambridge, where she is a member of the Department of Veterinary Medicine and also of the MRC Wellcome Trust Cambridge Stem Cell Institute. Her main research interest is to understand how neuronal activity can regulate oligodendrocyte precursor cells differentiation and myelin plasticity in health and disease. Her new line of research interest is to determine the changes in myelin and myelin repair throughout the lifespan. For more info on this talk and all talks in this series, check out our links below and follow us on Twitter at CamNeuro. See you next time.